All right. So welcome everybody to the January um, set of presentations in our Health Innovation Team series. These meetings are really formatable in any way that we like as a group. We're very open to suggestions about topics and presenters and um, really any way that we might be able to use this time in a valuable way. We've been very lucky over the past year or so to have a number of startup organizations in the Kansas City area that we've been able to highlight the innovation that they're bringing to the community and to, in turn, give them good feedback on their progress and growth and things that they might consider as they build out their organizations. So my name is John Fitzpatrick. I'm the community health strategist for KC Digital Drive. I've been hosting these meetings since about 2013 and mostly on a monthly basis. We take a hiatus that now and then, but you can see on our webpage the series that we've had really going back to that 2013 timeframe. Today we have a couple of really interesting topics. The first is with Don Peterson and his organization and solution PIM, and it is looking at how to really rationalize and contract the process of approval and right through reimbursement. And so that's kind of an exciting topic in today's world. And then hopefully we'll see Ashley McClellan join us for MedCurate, which is a online solution for more immediate and assured staffing relationships, particularly in nursing. So we'll look forward to that as well. With that, I guess let us kind of go around the table and do some introductions so that our presenters know who's here. And I'll start with you, Doug. And you feel free to go ahead and announce your item.
Yeah. So I'm Doug Hohulen. I'm on the Kansas City AI Club. I'm focusing on education and healthcare are two of my areas of focus. I will be presenting at the Greater Kansas City HIMSS webinar. Patients are bringing AI to the exam room. Now what? And so that's going to be on March 5th. I put a link to the webinar chat, and we'll highlight that 40 million people daily are using Chat GPT for health advice, and then also you have Gemini and other tools. So how to respond to those. So looking forward to that discussion.
Great, thanks, Doug. Elizabeth?
Hi, I'm Elizabeth Crocker. I am the founder of Emerald Venture Partners, and we are a strategic planning advisory and consultancy for medtech, digital health, biotech innovation from ideation to market. I'm also have a background in nursing and very dedicated to that. Doug and I are collaborating on a couple of things in and around nursing, AI, and so on, and nursing and how to, build nursing back up. So thank you.
Great,
It's good to
thank
be
you.
back.
Good. Don? Yeah, go ahead, Don.
Hi, I'm Don Peterson. I've been in Kansas City for about 35 years. I am I guess they say, a serial entrepreneur. I've started 3 or 4 different companies, 2 of which were complete washouts. One was a double, I think, maybe in baseball parlance, and then the last one was actually a grand slam. We exited that business. It was an infusion center clinic business. I started in 2012 and opened the first clinic here in Kansas City in early 2013. Today, the company has over 150 locations across about 20 states and continues to grow at 30 to 50% a year. We sold into or private equity firm took a majority interest in the company last year at a valuation of just over 1.1 billion.
That's
Well done.
Yeah, remarkable. Thanks,
Well
Don.
done.
Deb?
Good morning, everybody. Forgive my voice. I'm Deb Cisco. I'm the manager for patient advocacy and engagement over at University Health. It's nice to be with you.
Great, thanks, Dan.
Everybody, I'm Dan English, program coordinator, program manager, research coordinator. I do tasks at the KU School of Nursing.
Thanks. Stan? Stan, you're on mute.
I couldn't tell whether you said Stan or Dan.
Stan, sorry.
Okay. I'm Stan Edlovich. I'm supposedly retired, the faculty of both schools of medicine, but I'm still really involved in the field of pharmacoepidemiology and pharmacogenomics. So I'm playing around with that worldwide, actually, right now.
Thank you. Dick.
Hi, good morning. Dick Flanagan. I lead Digital Health KC, which works on the ecosystem supporting early stage and growth digital health companies.
Great. Robert? Robert?
Hey, I'm Robert Stoss. I'm with Community Care Network of Kansas, and don't always get here, but glad to be here today.
Good to have you. Jim? Jim Starso.
I'm sorry, I thought you said Tim, so my apologies. I'm Jim Startsov. I'm the Innovation and Entrepreneurship Manager at KC Digital Drive.
Great. David?
Hi, I'm David Varan. I'm a professor in family practice at the University of Health.
Thank you. Jeff Vanderhagen.
Hello, I'm Jeff. I'm a strategic account manager for Sanofi. So I manage 6 of our health systems in Kansas City, and we represent the vaccine division.
Great, thank you. Julie.
Hi, everybody. My name is Julie. I'm a communication specialist with Telehealth Rocks outside of University of Kansas Medical Center. It's wonderful to be with you all.
Great, thanks. Tamara.
Hi, I'm Tamara McMahon. I'm the director for the Center of Health Insights at the University of Kansas in the Department of Biomedical Health Informatics. I've been working in this realm since about 2012 in Kansas City, so I'm glad to be here.
Great, thank you. Jessica.
Hi, my name is Jessica Powell, and I work closely with KC BioHub to help activate investors in and outside of our region and ensure that they know all of the wonderful opportunities to engage with our local health systems.
Thanks. Ellie.
Yeah, hi. Sorry, I'm not on camera. I'm with Kansas Fiber Network, and we service connectivity to various businesses, but including healthcare. I really joined out of curiosity. I've been to an event before and really am interested in technology that's affecting healthcare environment and AI, et cetera. So just here to kind of learn.
That's great. You're very welcome. Sarah.
Apologize, I'm not on a camera as well. I'm in transit, but good to see so many familiar faces in the call. Helium, I'm the CEO of Helium. It's a reimbursable digital drug for areas of stress. We sell into VAs and clinics. We're located in a suburb of KC, just a couple hours in Columbia, Missouri, and it's delightful to be and learn in this call.
Great. It's good to know that we have a new suburb. Thanks. Raquel.
Morning, everybody. My name is Raquel Garcia, and I am the new executive director for Heartland Wellness Connection, a new wellness connection in Belton. And I've been a nurse for 21 years, so new to this whole tech world. So excited to learn as much as I can from you all. Nice to meet you all.
You're very welcome. Seema.
Hi, good morning. I'm also new. I think I got added to this invite from some of my fellow Digital Health KC people that I see on this call. So thanks for adding me. I'm happy to be here. I have a nursing background also, but I came straight into consulting at Oracle Health and now do project. Sorry, I think someone has a hot mic.
Yeah.
Whatever it is sounds delicious.
Go ahead.
Okay, cool. So yeah, I'll just make it short and sweet. I currently work at Oracle Health and heavily involved with Digital Health KC, run by Dick, of course. And yeah, stay really involved and actively volunteer throughout the digital health community and always encouraging friends and colleagues to join in when they can. So thanks again for having me.
That's great. Thanks so much. Steve.
I'm sorry, John, did you say Steve?
I did, yes. Go ahead, please.
I'm sorry. I think it was me that had the hot mic. I apologize. Hey, Steve Kropp, I'm the Director of Telehealth for the University of Kansas Health System.
Great, thanks. Jacob.
Hi, good
John, we're
morning.
having trouble hearing you.
Okay.
That's better. Whatever.
Okay.
Yeah, that's better.
Thank you. Go ahead, Jacob.
Hi, good morning, everybody. I work with Jessica Powell, and as she mentioned, we do an investor education series on behalf of KC BioHub, and it's a pleasure to be here.
Great, thanks. Ashwini. Ashwini, are you with us? Okay. Alexandria.
Hi, I'm Alexandria Hamilton. I am an AI skills trainer, so I'm really big on teaching how to use AI as a tool and as a thinking partner and not just like a genie or something. But I also have a background in healthcare my background as a data product manager at Children's Mercy, and then I also have experience working from Oracle Cerner. So
Great, thank you.
thank you.
Dennis.
Hey everyone, Dennis Ridenauer. I'm with BioNexus KC. We're a nonprofit focused on the life sciences and healthcare innovation ecosystems here in the Kansas City region, working right now on biomanufacturing, digital health, and rare disease. So, morning, John.
Morning. JD.
Hey, JD Tyler, MedPete's Doc, started Just Ask EB. It's a real-time virtual elbow support platform and service providing 24/7 clinical IT support for physicians and nurses caring for patients who need to learn or struggle or have issues with the IT they use to care for patients.
Great. Emily.
Good morning. I'm Emily Ng, and I work with Raquel Garcia at Heartland Wellness Connection. We're trying to bring out digital inclusivity out to the real community. So I'm excited to learn from you all.
Great, thanks. Jeff Shackelford. Jeff Shackelford, are you with us? All right, we'll check back. Sharayla.
Good morning, John. Thank you so much for the invitation. I'm
Sure.
Sharayla Haynes, the Community Partners Project Manager for Frontiers, which is a clinical translational science institute. We support investigators, so I'm excited to see what we can synergize today.
Great. Thanks. Bruce. Bruce, are you there? Okay, we'll jump to Scott.
Scott Schiffelbein. I'm a partner at PwC, focused in healthcare and health tech in the M&A.
Great. Okay. Looks like, is there anybody that I've missed? Okay, let's jump right in it. We have great topic to pick up on. Oh, we just saw Anna Harris join us. Anna, you want to say hi?
Jess, hi everyone. It's good to see everyone, and hopefully everyone's staying warm in this tundra. I'm in Chicago. It's been pretty cold. My name's Anna Harris. I work with Modern Health based out of the Overland Park area. I do our clinical operations side of things and have a ICU nurse background. So good to see everyone.
Great, thanks so much. Okay, as I said, let's go ahead and jump in. Don, would you kind of kick us off and let us know more about PIM?
Yeah, let me get unmuted here, and if you don't mind, I'll try sharing the screen if I can get the right one up here. Here we go. Um, can you all see the screen now?
Yes, it's not expanded though.
Okay, let me put it into show mode here. Does that help?
Perfect.
Okay, great. So PIM.health is a recent startup of mine. I am retired or supposed to be retired, and as many of you whose name I recognize and haven't seen for a while, great to see you all again, and also great to meet all of you folks I have not met before in person, and hopefully one day we'll get a chance to do that. Um, but last year I had an unfortunate medical thing that kept me on the couch for about 5 months. And during that period of time, I worked on this project because it was important to me to do so. And I want to share it with you because I think it's something that hopefully you'll consider important and potentially, a better system than we currently have today. There isn't a person or organization that I know in healthcare who hasn't or doesn't complain about the current system and the way it works. We spend over $350 billion annually on administrative overheads. Clinicians are spending, an immense amount of time on administrative tasks as opposed to the time they spend with patients. We all know the prior authorization delays, that the friction that they create in terms of delayed care. And of course, the post-claim submission post hoc negotiation over coding, payments, short pays, full pays, delayed pays, denied pays, appeals, and all the other baloney that goes with that. And so we're trying to replace that with a system that removes those points of friction so that clinicians can get back to clinical work, and administration can shrink from what it currently is, which is extraordinary when you consider the number of providers it supports and how it's grown over the last several years, and get it back to a more normal level of overhead and work, so that we can get back to providing better clinical care. We address markets that start with large self-insured employers. We have been speaking with Senators Marshall and Cassidy with regard to taking over portions of the ACA exchange, which with the HSA plans and price tagging that they have in mind, frankly, when you think about the current system, I've informed them that this idea of price tagging is very aspirational, but not possible within the current system because you cannot tell a patient what their out-of-pocket is going to be at the time of service. In fact, it takes weeks sometimes to tell them what their actual out-of-pocket is going to be, and oftentimes that's a surprise bill that everybody hates. We've had a recent discussion with Mehmet Oz, the director of or chief administrator for CMS. He's asking how we can help with Medicare and Medicare Advantage. I think probably some of you saw the Wall Street reaction to Medicare Advantage's very modest payment increase to the commercial insurances who provide those plans. And you saw the 20-30% drop in their stock price yesterday. And of course, there's a lot of dysfunction in Medicaid, especially the fragmentation of it across our 50 states, that Dr. Oz would love to see us find a way to modernize, if you will, and make more consistent so that people can get the care they need. We can cover the people that need to be covered, but we can do it without the waste, fraud, and abuse that currently exists. Let me explain to you exactly what we are. It's an adjudication system, if you will, for claim submission. We try to render every claim adjudicated within 10 seconds. We don't deal with any post hoc negotiation after the claim has been adjudicated, and that claim gets adjudicated at the time of service so that the provider knows exactly what they're going to get and the patient knows exactly what they need to pay. We do that through mechanisms that allow us to access the patient's accumulator data, their accumulated deductibles and out-of-pocket maximums, so that we're giving the patient an accurate out-of-pocket cost at the time of service, which then allows them to discriminate between different sites of care and the cost of the care that they're about to engage in. And if they want to seek a lower cost site of care or a different provider, we give them the information that allows them to do that. It eliminates prior authorizations that are administered by clerks and medical directors at insurances. We replace that with physician attestation as to medical necessity, and then we prospectively monitor every provider with regard to overutilization that is built on predictive analytics and machine learning, not AI. I know everybody wants to do AI today, and we're trying our very best not to do AI because we believe the actual information exists, and there's no particular reason we need to infer what people should be doing. We can actually tell them based on history what's been done before and done successfully, so they can do it again. Let me make sure to explain what we are not. Some people think we're a revenue cycle software. We are not. We don't do revenue cycle the way revenue cycle is done. We change the way revenue cycle is performed. We remove the cycle from the typical 30 to 45 day outstanding to a matter of hours. When the provider knows what they're going to get at the time of service, just like the patient knows what their out of pocket is, that provider gets paid within whatever time it takes to settle, basically like a credit card. So a day or two, the money is already in their account. We're not a clinical workflow system. We don't expect people to change their EMRs. We don't expect people to change the way they work. We look to the provider as if we're just another clearinghouse, so that when they're submitting claims within our system, they submit it down our clearinghouse rail. And if they're doing traditional, the way things have been, today, they can submit it down to the traditional rail, the Waystar, the Change Health, or whatever clearinghouse they're using. So we're not a rip and replace either. We can live very nicely next to the existing system and improve our benefit metrics while we work with each of the different providers who would install our system. And typically that installation would occur because the provider is part of the network in which we are working with the actual payers. And in that case, it would be the list of market entry points I mentioned on the previous slide. So we look like a clearinghouse. We would charge about the same as clearinghouses charge, 15 to 25 cents per claim. So the self-insured employer is not paying us. There's not another PM that we impose on them. Employers, payers, this is basically free to them for the most part because providers are already paying clearinghouses. And as I said, we look like another clearinghouse. The bullet points, pretty much cover the things I've just already said. We eliminate the post hoc denials, appeals, short pays, and the kind of overhead that every provider hates and spends way too much money and time on. And it'll hopefully allows those providers to put that money back into better clinical care equipment, telemetry for remote monitoring, and the kinds of things that we really ought to be doing in healthcare instead of spending it on administrative friction and things like that. But primarily we want to make sure the patient knows what the cost of the service is when they encounter it and can discriminate on their own as consumers should, like with any other purchase they make anywhere else in the world. There's no particular reason healthcare works the way it does, except that there are people, organizations, who benefit from that friction, who sit on hundreds of billions of dollars of provider money that should be in their pockets, but instead is sitting in an account somewhere at a payer collecting interest for extra 10, 12, 14, 20, 30 days, whatever it happens to be. And there's no particular incentive for them to pay any quicker than that. We eliminate that, and we want and believe that what we look like to everybody is simply a utility. We're not trying to change the world. We are simply trying to create basically like an electric utility. We provide the rail, and what you do with the electrons on your end is pretty much up to you. But we think in time it'll improve many things that currently create a lot of headaches and problems for people. And cost clarity being, I think the most important element of this, both for patients and providers who have been kept out of and abstracted from the cost of things. You can't ask a provider what something's going to cost because they don't really know. You can't discriminate on your own what things are going to cost. And we want to make sure that we eliminate that. We've told the senators that if they implement our system, that the aspirations they have for patients becoming consumers can actually be achieved. But under the current system, it really cannot. What is PIM built around? We are in the process of filing what we think are 12 patents. We think probably when they start breaking apart the different novel inventions in each of the patents we've constructed, that it may end up, at least our attorney has told us, it may end up being 30 patents, and that'd be great. But it's an end-to-end system. It's not a point solution. It doesn't fix coding by itself. It doesn't fix claims adjudication or denials by itself. It doesn't, there's not one thing it does. There's a family of things it does. And these 12 patents are all tied together from end to end and complement each other and derive their benefits or their functions from the other patents that are actually in the family. But what we've created everything from the prior authorization system using medical necessity and evidence-based medicine to approve those prior auths on the fly, given the physician attestation. And we have gone as far as even to create a marketplace where you can simulate an encounter, go online, make your complaint in natural language, and try to come up with a simulated encounter based on that input in terms of what you would present with at the doctor's office. And from that, render a cost to the patient with regard to that particular problem. We're taking the entire ICD-10 world and eventually to ICD-11, as well as all the CPT and HCPCS codes and DRGs, and we are translating those into natural language because you can't put a price tag on a CPT code and expect the patient to understand what the heck they're looking at. And when there are 70,000 different ICD-10s, it's a little hard to come up with a specific diagnosis that goes with those CPT codes. So we're converting all of that to natural language so that people can actually speak in English and get the information that they're looking for. I'm going to leave this slide up. It just basically explains all the different things I've just covered, and then open it up to questions. So I'm sure you have many, or maybe have many, and I'd love to address them for you.
Yeah, that's great, Don. Thank you very much. It seems, I mean, you have described kind of two ends of the spectrum. One is kind of the depth of the solution going and potentially blowing out into 30 patents. But on the other side, saying it doesn't represent a radical change. I think truncating the whole process, as this would seem to do, would be in fact a radical change. When would you see kind of rolling this out? Do you have to wait on those patents, and what sort of timeline are you looking at based on that?
Yeah, so let me address your first point about radical change. Yes, this is a radically different system than the one that currently exists. However, the system speaks X.12, which is what clearinghouses speak now between payers and providers. So when you implement our system, it looks just like an existing system. The system just does a lot more than Change Health or Waystar or Trizato or other traditional clearinghouses do, because right now clearinghouses are strictly traffic cops. They just route the claim after they scrubbed it, of course, to whoever the payers are that the member ID would indicate. In our case, we actually adjudicate that claim on the fly once the claim is or the encounter is closed and the claim is submitted. So it's not radical in the sense of implementation. It's radical in the way that it handles things, but the implementation is actually quite natural in the sense that it can live alongside the existing system and speak the same language that the current system speaks. so that nobody has to change any workflows that they're currently doing, except that when they submit it to us, they get a response that's a lot faster than the one they get now. The patents themselves, John, to address that question, we're filing some of the actual patents this month, actual applications, not provisionals, because our search results have told us that in some cases there's really nothing else out there that surfaces that's close to it. So we can file those as full applications. The others where there are potential workarounds or articulations we have to make about the specificity of our novel invention and the fact that it attaches to other elements of what we're patenting and the different patent numbers. Those take a little bit longer. We'll probably file all of those provisionals here in the next 30 days. And then over the course of the year that we have to clean them up, we'll be cleaning them up. But our goal is to get them all cleaned up by, frankly, the end of March.
Hey, Don, I have some questions. Ms. Davis.
Yes. Hi, good to see you.
Yeah. How do you differentiate yourself with all of the vendors in this space that are also implementing AI? That's the first question. And the second question, are you addressing the growing problem of suspected conditions based on claims about from a patient that are coming from multiple different sources of clinical care?
The answer, I guess, to the first question is we're aware of people out there who are trying to fix or improve the efficiency of the current system. Making coding AI based and trying to predict what good codes should be. We know even the insurers are using AI for prior authorizations and denial management and things like that. Our goal would be to eliminate the need for any of that, because we would agree, the payer and us would agree on the front end, that if we can present a claim or a episode of care with a high enough confidence level that it's coded properly and approved and based on medical evidence and other standards, that we can approve that claim immediately and adjudicate it on the fly. So there's no post hoc effort or work that needs to be done once the claim has been adjudicated. Just like you go to Amazon, you buy something, you're not negotiating later what you'll actually pay for that item. You bought it, it's over. The transaction is approved on the front end. That's what we intended to achieve here, not improvements to the existing dysfunction that's out there. A lot of point solutions out there are trying to fix different elements of a abysmally inefficient system, and it's for good reason. I mean, I don't discredit anything they're doing, but frankly, they're only solving a piece of the pie or the piece of the puzzle, and frankly, we're trying to create a new puzzle or a different puzzle. Okay. And then you asked about coordination of care. We have a complete federated consent rail for the exposition of medical records, as well as HIPAA forms and things like that, so that we can get out of the business of handing people, clipboards when they walk into the office. And if we need to move medical records, we've already gotten their federated consent. And if a provider is within the network we contract to, then that provider can invoke that federated consent and get the patient's medical records whenever they need to, however whatever, using whatever technology is available. Again, if your EMR doesn't permit you to export medical information, then of course that's a limitation of that EMR. We can't change that. But where there are facilities within the EMR to condense or to communicate a patient's medical record, then we would have federated consent to access that and then transport that to another provider. Does that make sense, Dr. Brand? Did I answer your question?
Well, I think maybe. I mean, your terminology sounds suspiciously identical to what Oracle is pushing on our claims adjudication internal AI usage. Sounds almost the same verbiage. And secondly, the issue is reconciliation, a source of truth for the patient. So we have a bunch of nurses that spend a lot of time responding to queries from third-party payers that have received claims on an individual when they go to a minute clinic or they go to an emergency room in another facility to ask whether this person does indeed have this condition or not. And that churn represents the fact that there is no balance forward in medicine these days. Everybody's submitting different claims using different codes. And one of the things we physicians and patients really need is there a source of truth about their current condition that can float to the top? And I think that's where AI could really benefit by um, looking at the claims and then looking deep into the EMRs from which they originated and find out whether there is truth to that specific code that was chosen. Not so much the CPT code, but the ICD-10s that justify that CPT code.
Yeah, I think Dr. Baran, you're talking about the current system and its dysfunctional post hoc negotiated reviews based on what payers would like you to believe is inconsistent or incomplete data. Why, when we create an encounter, can we not properly code it at that time? Why? The truth exists as to what correct coding should look like, and there's enough experiential data to season that ground truth, if you will, with actual episodic coding that's been paid in the past for a given ICD-10 and the CPT codes that accompanied it. Why is it still negotiated after the fact? I believe, and I'll, assert that I believe it's planned in, it's built in. It's like, when you call a call center and there's a planned hold. There shouldn't be a negotiation after the fact if coding was done properly on the front end. And if the coding is done properly on the front end, then the claim should just adjudicate and pay. There shouldn't be some post hoc negotiation over whether or not the coding was right. That's what creates the delays in getting paid. That's what creates the delays in getting patients the information they need about what they're spending. That's why they don't find out for 4 or 6 or 8 weeks what their actual out of pocket is going to be for a given episode of care, because negotiations are still going on 10, 20, 30, 40 days after an encounter has been had. That's where the surprise bills come. That's what politicians and policymakers hate. Patients hate them too. And it causes medical debt, it creates all kinds of problems. We're trying to solve the problem at the front end. Get the coding right on the front end, payer agree that this is the coding that should accompany this diagnosis, and pay it. Let's not negotiate after the fact. And we're eliminating that. That's why I say we're not implementation wise a radical change, but we are radical in the way that we handle claims that have traditionally required post hoc review and negotiation and delay. That's to be eliminated under our system.
Hey, John, there's a lot of hands up, so why don't we? I'll let you do it. But I mean, this could. Do you have another topic for today's presentation?
Yes, I do. Yes, I do.
Okay, all right.
We have about 5 more minutes that we can spend here. I realize it's a huge topic. I want to first get to the comment from Sherry Tawhid. She says, you mentioned 2 alarming statements. It's like utilities. I personally feel utilities are very problematic and you have no choice. Second, you mentioned that it is your system would make healthcare or would be a commercial market. Could you elaborate on what you mean?
Well, I guess I can only answer the first question with a question. I'm not sure what your concern is about the label of calling us a utility. The utility label I use is to indicate that we are independent, unaffiliated we are not part of a payer. We are not a payer. Today, every payer has their own adjudication system once the claim gets to them through the clearinghouse. And that system is completely opaque. We don't know exactly what happens within that system because each of them run their own. What we're creating is a system that's totally exposed, that everybody can participate in, just like a utility, and not get what only that payer wants you to see or to know. One of the biggest problems self-insured employers have right now is maintaining their fiduciary responsibility when they lack insight as to what exactly is being paid and when it's being paid and what's being paid for. And the ERISA requirements are being contracted away to ASOs and to TPAs who basically contractually fulfill the fiduciary responsibility employers have, but employers still don't know what's going on with payments within the system that they're spending so much money on. And that, frankly, according to ERISA, is, well, not sticking with their fiduciary responsibility. So, the label utility just simply means that we're a democratized system that everybody can benefit equally from, and not a closed system or a proprietary system from which one entity benefits over others. I'm trying to remember now the second part of that question. John, help me out here.
On to Doug. He's had his hand up for a while.
Yeah, John, you're on mute. Yeah, just real quick, great presentation, Don. This is a huge challenge. I gave a talk to American Association of Medical Coders, and some of the challenges, especially with AI, where you basically AI is denying from the payers are using AI to deny. It's just causing more paperwork, which is causing more costs to the providers. Then the patients get surprise bills, and then they file claim denials. Before the percentage was just less than 1%, and with AI, it's very easy to create a appeal letter. In fact, I posted in information about this. So I really think your solution could really help. That everyone knows up front very quickly with AI. What is the cost, the true cost? Because one of the big problems I actually find from a personal perspective, I was going to get an MRI. And I could not get it's like, okay, I have a high deductible, and what is the negotiated rate? And the answer from everyone after lots of calls was, you won't know the negotiated rate until after you get the bill. And it's like, well, I'd rather just pay out of pocket than if that negotiated rate, especially if I haven't met my deductible, which is very high because I'm on the Affordable Care Act insurance. It's like, how do I balance, pay out of pocket, use my deductible, all these things. Will I meet my deductible? All these challenges. So anything that could help with that, especially, I saw your Substack on how many people don't, go bankrupt because of this. And this is an absolute critical area. So I really applaud what you're trying to do.
Well, thank you. I appreciate that. And I would encourage anybody to go look at my Substack. I've written extensively on these various topics and the waste that we unfortunately are taxed with in what, it might be $350 billion in waste. And we think of that as, well, that's small compared to the $5 trillion we're spending. But take that $350 billion and pour it back into improving clinical care. And I think we can make some meaningful strides. So Doug, thank you. I appreciate that. And, appreciate you subscribing to my Substack as well. But to me, this is a generational kind of thing. We don't expect adoption to occur overnight or, in great swaths all at once. But the fact that we're in the conversation with regard to the Affordable Care Act exchange, Medicare now with Dr. Oz, we're talking to coalition leaders across the spectrum. I mean, across the U.S., we've talked to multiples who see employers as the most likely early adopters of this because their need is so acute. And their desire to save money is, well, acute as well.
Hey, John, Don, this is a big lift. And whether it can handle the entirety of healthcare system, inpatient, outpatient, and ancillary services, I think is, worth exploring. Some of you guys know I have a little adage, and I'd say healthcare innovates at the speed of trust. And the reason why we have all these systems is because we don't trust the claims that are coming from the providers, and we don't trust that the insurance companies are paying us fairly. And the systems that have worked, including what Cerner did some years ago, is these trust relationships that say, I trust, but I verify. It's the old, Reagan, weapons thing. So trust but verify. So there are systems that have been built and operate quite effectively where everything goes through. Claims are not, and then at the end or at a quarterly period, we go back and see whether the trust should be earned and continued. That's what I see you doing here is that, but it really requires the pick and shovel work is trust, is getting a group of providers and a group of payers to understand that we're actually not trying to screw each other. We're actually trying to deliver safe and effective care in a timely manner for the benefit of the patient. So I think, honestly, if you could put that at the center of the narrative, I think people would at least for me, I love what you're trying to do. I think it's an incredibly big lift in the system. And it sounds like you've got some clever ways to think about it with your patent portfolio that's emerging. John, this is probably a KC work group. I'd love for us to, surround this, and because there are a lot of smart people on the call with a lot of experience that could probably help Don and his team move this forward.
Okay.
Thanks, Jake. I appreciate that. And I know that, with your background and the connections you've had to Cerner, that input from you all would be extremely important and valuable to us. And I look for that. We've talked to, like I said, coalition leaders, we've talked to senators, policymakers, we've talked to their healthcare teams, we've talked now to Dr. Oz. People want modernization. They need us to be in a system that is more like the current credit card system or other transactional systems. And there's no particular reason why it's 40 years behind everybody else. It's only lack of will, in my opinion. And will it be perfect from the get-go? No. I had a family physician ask me the other day, how many claims do you actually think you can clear in real time? I said, I don't know, 70 to 80%. And she said, well, I thought you were going to tell me a number much higher. And I said, if I paid you for every claim up to 70 or 80% of what you're currently submitting right now, isn't that better than zero? And she said, well, of course. I said, okay, we'll get better over time. That's what learned systems are. That's how, machine learning works. It's not going to be 100% right up front. But if we're, manually adjudicating 20 or 30% of current claims as opposed to 100%, that's still better. And, better is better than nothing. And the system has to change. It has to get modernized. Otherwise, we're going to continue to spend hundreds of billions of dollars a year on wasted administrative overhead. And that's my mission, is to fix that. And the fact that I've been successful in the past, I have the patience and the resources to help make that happen. And I'm willing to put that to work. I'm 71 years old. I'm looking for a CEO. I don't want to be the day-to-day operator, but I am bound by this mission, quite frankly. And yes, Dick, you're right. It's a heavy lift. But you know what? Somebody's got to do it. It might as well be us.
Yeah. This is tremendously stimulating, Don. We really appreciate this. I think we probably ought to, per Dick's suggestion, kind of think through a potential working session. That would be great.
Yeah, I'd love that.
Thanks for raising this up. This has really been a super thing. Thank you, Don.
Okay, thank you. Thank you for your time.
Yeah. We're going to kind of jump thoughts here now. Ashley McClellan has joined us. She is the founder and CEO of MedCurate. And MedCurate is really a new view toward how it is that efficient, effective staffing can happen in the modern context. And so we'll let her go a little deeper with that for us. And Ashley, I invite you to say hi. And if you want to share your screen, we should be able to do that.
Good. I will. Good morning.
Morning.
Let me get my screen driving for us to make sure you're seeing what you're supposed to be seeing. All right. Well, good morning. I'm Ashley McClellan, and I'm really grateful for the time with you all this morning. My background and my mission is to partner to cure the healthcare staffing crisis. So I was fortunate to be a healthcare executive with HCA for 18 years, served as a COO and then CEO with them in Kansas City, Dallas, Houston, and then back to Kansas City, where I was CEO at Research Medical Center, Research Psych, and the College of Nursing from 19 to 23. And throughout my career, even before HCA, when I was with pediatric nonprofit hospitals, the number one issue running the hospital was staffing on a daily basis. In the end, people taking care of people. And it really became more prevalent to me during the pandemic, when Research was one of the hub hero hospitals to cohort COVID patients. And on a daily basis, when I was on call as the administrator accepting transfers in, I'd get calls saying, hey, we have a STEMI coming your way. And we also, another hospital would call and say, we need to send you a COVID patient. All my ICU nurses would be full. I'd call an agency and say, hey, I need 2 more ICU nurses tonight. And they'd say, okay, that's $200. You want them or not? And it felt like a hostage negotiation. I maybe was authorized per my company to go to a different rate. And so I'd have to call back those sending facilities and tell them we couldn't take their patients. And this would happen 6+ times a day. I'm sure many of you experience this with your patient populations as well. And so I thought, how can we change this so that the agency is not in control, that we give the control to people actually taking care of the patients, which are healthcare organizations and healthcare providers. So I left Research Medical Center in March of 23, had great support from many of you on the call in the healthcare ecosystem, and built out the tech and platform, what is now called MedCurate. So MedCurate, I can drive my screen. We expertly match healthcare providers and organizations for half the cost. So if you think of it on a daily basis, healthcare organization-wise, we partner with any healthcare organization with the exception of nursing homes. And on average, hospitals staff to their core volumes, which is the lowest 3-month average of the year. This is consistent across all types of health systems. And so they staff to their lowest core volume of 3 months, and then they flex up with part-time or overtime or agency. And so when they need to reach outside their organization to reach out to those healthcare providers, their only conduit or way of doing so has been through traditional staffing agencies. Those staffing agencies are typically charging 50 to 200% markup in service fee. And what they're telling the healthcare organization is a bill rate. So that hospital CEO is told, hey, we need to charge you $150 an hour, but they don't know of that $150 what's going to the clinician versus what's going to the agency. So those agencies are also directing these healthcare providers and telling them where they're going. And so I developed this platform, which I'll demo here in a moment, where we come in and we have a transparent service fee model so everyone knows what our fee is. And healthcare organizations actually choose the rate that they're posting at, and providers see that directly. On the back end, when we invoice the facility after MedCurate pays the clinician, we invoice the facility and show that service fee so everyone knows where we stand. Through this, we have found great success with our clinicians as well as the organizations. We've gotten rid of the kind of traditional middleman by leveraging technology in this digital marketplace, and have had a great feedback from our clients. So I'm going to stop sharing this and jump over to share a quick demo, if that's all right, John.
Sounds great.
Okay. So, all right. So this is what it looks like for a facility leader. We're in a demo mode. This is St. Joe Medical Center. Lori happens to be their CNO. And so when we work with an organization, we learn what their demand and needs are. So for this example, they need med-surg, ER, and ICU. We onboard the organization by getting basic information about the facility, so the location, the email, address, main contact. And then this worker information is what's visible to clinicians that are considering picking up the shift. So where to park, anything specific to COVID, uniform requirements. Clinicians check in and out through our app. We have an Apple app and Android as well as web-based. They do so because that's how they're paid by MedCurate. We can also have timekeeping integrations with a health systems system if they so choose. We capture meal break expectations, values, etc. And then this upload section, we can have facility photos and logos, but really the magic in the technology is the matching and crosswalk between a facility's job description and the licensure, competency, and credentials of our clinicians. So if you require ACLS for a shift, the clinician that just has BLS will not see it. We also have all of the credentialing requirements with expiration dates, etc. And no one can work with any expired licensure or certifications as a result. So that safeguards credentialing perspective. If a facility wanted to post all of their med-surg shifts at the same rate, again, they're choosing the rate that they're paying. They would input a default shift rate here so that the med-surg manager on 4 North isn't posting a different rate than the med-surg manager on 5 North. And then maybe there's a new leader for the organization. They can self-add that user on the platform and what permissions they want them to have. So it typically takes us about 30 minutes to get that initial information from a healthcare organization. And once we do, they have a dashboard. So this is one that we've used historically for demos, but you can see different shifts posted here with different statuses, such as completed, filled, not filled, open. So for purposes of our time together today, I'm going to post a med-surg shift. With MedCurate, you can post 1 shift at a time or a block of shifts. Most traditional agencies require an 8 or 13-week contract, but sometimes maybe you need to just cover a 2-week FMLA. Or, hey, we just need extra coverage on Fridays because we have a surgeon that likes to do block cases on Fridays. So I'll choose our time together right now. Let's see. So we also have facilities that do obviously more than 5-minute shifts, but they might do a partial shift, like 6 hours for admits and 6 hours for discharges. So again, it's completely up to the facility. The hourly rate, again, they choose what that is, and that is the rate that goes to the clinician and the rate that they see. It's reminding me that I'm posting a 5-minute shift to make sure it's not a typo. I'm aware. And so that shift is now live on the dashboard here. So it's a real-time, living, breathing dashboard. So I'm going to jump over to the clinician view. All right. So this is demo nurse. Again, he or she logs into their app or is looking at their computer, and they have a few extra minutes this morning. When they click on available shifts, it will show them all the different shifts that they can pick up based on their licensure, competency, and credentials. So I'm going to pick up this shift. This is that worker information that's gathered that one time on the front end, including the full job description. And if that looks good to me as the clinician, I'm going to say I want to pick it up. When our clinicians join the platform, they have a user agreement with MedCurate. It includes details that if they no-call, no-show, they're fined and removed from the app. If they call in between 0 and 72 hours before that shift starts, they're fined. And if they have multiple call-ins, they're removed from the app. So one of the kind of historical concerns with per diem work is that people are less reliable. And so we have safeguards in place to try and deter that behavior by having these policies in place. And as a result, we have very few no-call or call-ins. When demo nurse picked up that shift, it sent a notification to the facility through a push notification in the app, through an email, and shows up on the dashboard that it's been filled. Our leaders love getting that email. And so now demo nurse is going to clock in. Again, this is through their app. It reminds them of the shift information. They click clock in. And they are now clocked in on their shift. So while they're clocked in, I thought I'd talk a little bit about our go-to-market approach. So when we learn about the demand of an organization, we get basic information such as, where are your primary needs, those job descriptions, the rate you want to pay, and the estimated need. Is it 7 days a week? Is it one person every other week? Is it 5 people a day? And then we go source to that. We source under our umbrella MedCurate because we don't want to be in competition with our HR and sourcing teams. And we'd say something like, hey, we have a great opportunity in Kansas City, Missouri for med-surg shifts, pay up to $55 an hour, pay initiated within 72 hours of shift completion. Sign up at MedCurate today to curate your healthcare career. And then we walk them through our Joint Commission CMS approved credentialing process where they're self-uploading a lot of these different documents that we're validating. So we do primary source verification for licensure, we do employment references, all the vaccinations, certifications, as well as a third-party background check and drug screen. We have a clinical director on our team as well that reviews anything that might need to be reviewed by a clinician. And once they meet all those requirements, they are eligible to pick up shifts. So I'm going to finish the process real quick. When demo nurse goes to clock out, it asks if they had a meal break. Did not for my short shift. Demo nurse confirms, yes, that is what I worked. And when they do, it sends a notification again to the facility saying, hey, good news, your shift has been completed by demo nurse. Take a look and approve their time. And so now on the live dashboard, they'll go in and see it's pending approval. That leader can see what was scheduled versus what was actual and confirm they're okay with that. If they think there needs to be any edits, they can submit that. That will reconcile. Otherwise, when they click approve, demo nurse just got paid by MedCurate. So we have an integration with the payment platform that pays these individuals timely. So that's a high level version of the demo. I will pull back up the slides to talk through the rest. All right. So now that you've seen what it looks like, let me talk about maybe what makes it a little bit different. So through this model, both sides win. It's not one side saving money to the other's expense. We are able to decrease the expense for healthcare organizations by about $15 an hour per nurse FTE, which is over $30,000 per FTE. And on the other side, the healthcare providers are reporting they're making at least 20% more. A lot of that savings comes through the tech enablement, as well as our clinicians that are picking up are independent contractors. So we don't have the benefit and tax costs associated with those individuals, and we pass on that savings to both sides of the marketplace. Also, they're in direct contact with one another and in control of that conversation. So we are not directing where they work. They get to choose, which is really beneficial for them as well. Most people that are in healthcare staffing have a sales or tech background, not healthcare leadership. And so our team focuses on really making sure that we're being a good partner and building solutions that really relieve the pain points of our healthcare leaders today. Healthcare staffing agencies have a bad reputation. And so being in somewhat that space, we're trying to take away all the things that weren't beneficial to those that were participating in that. So things like, we don't have a placement fee. So if Nurse Ashley works for John a shift at his hospital, or 10 shifts, whatever the number is, and it's a great experience and I want to go work for him directly, we don't have a fee to allow that individual to go. We actually support that transition. We share the full credentialing file, make sure they have what they need to onboard Nurse Ashley. Most agencies charge 15 to 20% of an annual salary to convert that person. We also don't have long-term contracts and cancellation fees. So the only fee that we have is if an organization cancels a shift within 24 hours of it starting, we ask that they pay that clinician $4. But we give a lot more flexibility to both sides of the marketplace. So where we are today, We launched at our first hospital in February of 24 at Golden Valley Memorial Healthcare. They've been a fantastic partner for us. On the supply side of things, we have 500 plus on the platform. We have thousands that are at different stages of credentialing. We only finalize credentials for our healthcare providers when we have demand for them, because we want to ensure that their competencies in background check and drug screen are as close to their start date as possible. Again, our healthcare providers report a 20% increase in compensation, all recurring to the platform, with our acquisition cost per FTE around $130, and we clear about $160 in per shift revenue on average as the company. On the demand side, we're at 73 different healthcare organizations now. We're across 9 states as of this week. We're supporting hospitals, surgery centers, post-acute rehab, and home health. We have several regional and national partners that we're working with, that we're piloting in one market and then growing with them to the next market. Again, they're reporting about 30,000 in savings per FTE, with them all expanding their partnerships. It's interesting, Missouri is the only state we're licensed in date that requires staffing agencies to report what they're paying to the personnel versus what they're charging to the facility. And for all of 2024, they haven't produced the 25 report yet. On average, it was 108% market worth it. So that's always helpful, and it's publicly reported data to share. So I can go through details. I don't want this to be a sales presentation for this group. I'd really like to have more discussion. But I think at a high level, rates are posted directly, a direct connection, more flexibility. We really serve as their local float pool. So for many of you who may have managed a float pool in the past, that is very challenging. And so our technology enables that very well. Again, less service fee, no placement fee. We maintain all credentials. No upfront fees or any other model. The only time we get paid is when someone works at their organization, and that charge is going to be less than they're paying today. So I'm glad to share follow-up materials. I will not make you watch my demo video. But one thing that is exciting is we are launching currently what's called MedCurate Enterprise. So you've seen the version of the technology that supports the external float pool of the MedCurate clinicians. We have a white label solution called MedCurate Enterprise that can be its own instance for a healthcare organization that wants to manage its own people. So if the hospital has a float pool and they have clinicians that work in that float pool, the way that it typically works is, oh goodness, we need 2 extra ICU nurses tonight. That manager is calling and texting and sending group meets to everyone that worked last night to see if they can come in tonight. And maybe there's sister facilities that share staff, so they're calling those leaders to do the same thing. Through our technology, they can have their own instance where there's push notifications when there's open shifts, and their own internal people can fill them. And if they're not filled internally, they have the option to have it promoted to our external clinicians at MedCurate as well. So we're launching that. It's technically live now, but it's in test mode for a group of 12 sites in Minnesota. But we're eager to offer this to our current partners as well as future healthcare organizations. So would love your feedback and would love to connect, and I'll stop sharing my screen and I'm glad to answer questions.
That's great, Ashley. Thanks so much. It just seems to me that the level of sort of transparency and efficiency you've created definitely hits that win-win that you were looking for. It just seems so much easier than what people have contended with to date.
Thank you.
Yeah. So altogether, how many clients are you serving today?
So we're at 73 healthcare organizations across 9 states.
Great.
And really both sides of the marketplace are our clients. The 73 are the ones that pay me, but we have over 500 clinicians that pick up
Sure.
across those 73 sites.
Sure, that's great.
Mhm.
All right, so I'll open up to questions to the group. What would you like to follow up with Ashley? Dick, do you have a thought?
Yeah, first off, Ashley, incredible progress by you and your team. I pulled over here because I wanted to make a comment as I'm headed back home from earlier kid drop off or grandkid drop off. But look, Don talked about in the previous about creating this transparent system on both sides. I think you are living in that principle of building trust among the providers and the purveyors of talent. And I think the way you characterized what you do on a technology platform versus what the agencies do, the thing that I think all of us recognize coming out of COVID, the agencies, and I'm sorry to use this term, but raped the organizations. It is one of the worst examples of breaking trust with organizations to what they did to those hospital and clinics and everybody else during COVID. And people have like, there's got to be a better way to do this. Similar to what Don said earlier, there's got to be a better way. I think Ashley has found a better way. And I think this is one of the companies we need to support and promote broadly in the digital health ecosystem for KC. But as you already heard, Ashley is getting traction well outside the market that, we know is this kind of, central heartland market. So I think this is just one of the great innovations. And the other thing that I just would point out is Ashley said it in her opening comments. She's coming at this from a provider perspective. And almost every staffing solution I've seen is coming at this either from the tech side or from the agency side. And I think she's got the right team, the right attitude, and it shows in the early success she's enjoying. So Ashley, kudos to you. Continued good work, and hope we continue to support you along the journey here.
Thank you, Dick. You guys have been so helpful already.
Ashley, this is Don Peterson, and I want to again also echo what Dick said. Congratulations on taking a difficult process and turning into something that is accessible to all parties on, as you say, both sides of the equation. I think that's largely what's been missing. I was actually in the hospital business back during the pandemic, and I watched nursing rates go from $83 an hour to $300 an hour. And, our politicians in Missouri thought they would help solve that problem by throwing even more money at us hospitals so that we could compete with the big city hospitals for nurses. And all that did was drive the hourly rate from $150 to $300 an hour. I even called the Attorney General's office and I said, "Is there not a price gouging law here in Missouri?" And you probably know this. There's not. There is for B2C, but there is no B2B price gouging. And I know the owner of one of the big nurse staffing agencies, and he literally took his family to Australia and New Zealand on a private jet with all the money that he made during that period. And it was egregious. So I congratulate you for trying to, straighten this out. It's a mess. Now, the one concern, if there is any, and again, it's a small concern in the overall scheme of things, is that my experience with travel nurses, agency nurses, is their inability or unwillingness to learn our systems or workflows. And that disrupted a lot. And here you are, you're paying a great deal extra for, these nurses to come in because you need them on staff. A lot of times it's just because you have to meet staffing ratios. And yet, what are you doing to ensure that your folks are, not only able but willing to learn not just the workflow, but the systems that, these hospitals have? How do you handle that?
Yeah, no, great question. So when we onboard a clinician, we are learning, what EMRs are they proficient in, what systems have they already worked in, et cetera, as well, because it's important to us that it's a good fit on both sides. It's not just a body. We work with the healthcare organizations to know what their onboarding preferences are. So I'm sure it's not surprising. Every health system thinks their process is unique, and it is to them because it's what's important to their culture. And so we work with them to build that orientation. Sometimes that's an orientation packet that our clinicians are reviewing prior to a shift, and then they're showing up for a 4-hour orientation before they take a patient assignment. We curate whatever that organization needs it to be. On the back end, we get feedback after a first shift on both sides to make sure it was a good fit. If the clinician doesn't want to go back, they don't have to. If the organization doesn't want to see that person back, if it's, hey, they're fine, they're just, they're not bringing an A attitude, they can give us that feedback, and we actually make them, you'll like this, a DNR, a do not return. And so that clinician won't be eligible to return to that site. If a clinician has more than one DNR, then they're not eligible to pick up on the platform. We don't want to pass around bad apples. Maybe I just had an off day and didn't gel with the manager, but every other side has said I'm fine, so we want to give them more than one strike. If it's something clinical, like they aren't properly documenting meds, we educate them. If it's a true concern, they're off the platform. And we have the ability to do that with their 1099 status and per their user agreement. So we also do reviews from our perspective, as well as from the organization on them annually per joint commission.
Okay, good. Well, as I tried to do it during my presentation, is point out where the administrative overhead creates lack of payment or short payments to providers who desperately need them because they're operating on such thin margins. And when you bring in agency nurses, sometimes getting all of that information in the right place so you can close the chart, submit a claim that's clean and code it properly and all that is challenging. So I'm glad to hear you're addressing that to make sure that those nurses are actually performing the full spectrum of what's required, not just to provide clinical care to patients, which is why we're all here, but the administrative side of this thing and getting paid for it is such an important aspect of it that you just can't divorce yourself from the other. So you've got to do both, unfortunately. And so I'm glad to hear that you're addressing that. That's great.
Thank you.
Thanks, Don. Other thoughts from the team?
I think one thing that would be helpful for me, John, is depending on the healthcare organization determines the best point of entry for me. So if it's a freestanding hospital like Golden Valley, their CNO and CEO collaborated and we launched this. If it's a larger regional health system, is that the shared services leader? Is that a regional CFO? Is it a regional staffing office? Is it a CIO? Every place has been different. So I'd be curious if you have any insights from this group, maybe for some local access points.
That is a great question and a good way to use this group.
If you don't mind me asking.
No, absolutely. That's why we do this. So does anyone have any thoughts on that? I think that is a key question.
Let me offer, in my experience, Ashley, that you have to do both. So let's say it's a regional system or an SSM or somebody like that. You've got to go to the individual facility that's struggling for staffing and identify that need there. And then if they say, yes, we need you, then the push up the chain becomes a little bit easier than to go to the corporate office and try to push it down. Where you're pushing instead of being pulled. And so my recommendation, if for what it's worth, would be to start where the problem exists, where the friction is the greatest, and indicate to them how you can solve their problem, and then they will champion you up the chain if they have to get approval from their regional or market people for each of, because they separate into different markets too, so they have different. Oklahoma, they have a different set of management people and folks in charge of this. So sometimes it's just hard to identify who's the right person to go to, no matter where in the system they reside. So, if you start where, the facility has the problem, it makes that navigation a little bit more navigable.
Yep. Exactly. I've been fortunate to be a peer CEO, and so those are typically my, targets. Sometimes they don't have as much detail around the specific issues, and so it's to your point, a top-down, bottom-up approach.
Yeah.
Great.
Other thoughts from the team, right? That where to plug in is a very key question, and one that I've certainly dealt with in my business life as well. You had mentioned actually that sometimes your point of entry might be a CIO. That given it sort of seems to me that the technology here is really just an enabler, that it's really the overall approach that matters. Then it might be more like a CFO or a COO that would be looking at those things. Have you had a connection through a CIO? How does that help you?
No, my typical connections or routes are CNO, CFO, COO, CEO. And so depending on the size of the organization and who, from a technology perspective, assesses new tech enablers or tech solutions, I didn't know if that would be an appropriate route based on this team's feedback or not. So
okay. Any thoughts on that, folks? Actually,
hey, John, I don't want to, I've already made comments earlier, so I'm not sure I wanted to jump in again, but I think you have two different, and we've talked about this. When you go to the enterprise level, you're going to have to involve IT and those kinds of things. But the lesson that I've learned, selling technology into these places is this is absolutely the bear hug kind of sale. You got to grab a hold of the organization. You might get centralized support, but I think we all recognize that when you're trying to staff a shift, it's incredibly local, and relationships matter between whoever's trying to fill that and whoever is filling it. And I think what you're doing is building trust locally between people that can provide service and people that need those services. So you can spend all the time you want calling on a senior executive that says, hey, we got this new platform, use it. And they're like, no, I don't like the people they send me or whatever. So I think it's really, you got to do both. And particularly now at the enterprise level, you're going to be dealing with IT and cyber and everything else. Not that you don't deal with it today, but you'll have a different set of questions. And it'll be a different sales process, but it's also one that gives you leverage at the platform level, not just at the staff or the shift level. So anyway, that's what I would say.
I appreciate that.
All right, John,
yes, go ahead, please.
I don't know what's wrong with my in Zoom hand holding thing, but Ashley, it's nice to meet you. I'm Elizabeth Crocker, and I am a registered nurse, although I retired from clinical nursing. But I worked as an agency nurse during my entire 20-year nursing career for extra money, because we obviously didn't get paid much, but that's beside the point. And I was very specialized, so that's another thing. I only worked in intensive care units. At the time, and to the point that Dick is making, everything was driven up by human resources and, the supervisor of nurses and so on and so forth. And it's a human resource problem, resourcing shifts and so on, and also any specialties such as the one that I have. So I'm not going to spend a lot of time. I will connect with you. I'd like to meet with you because I'm going to talk with you from my years of experience. And the fact that a number of people know that I am still very dedicated to nursing and to staffing for the patients. That's kind of what I do. So thank you very much. I think you've done a great job. I'll be in touch through LinkedIn. Okay.
Thank you very much, Elizabeth.
John, I'm going to sign off. It's good to see everybody again.
Thanks for being here, Elizabeth.
Yeah, I'm back in town, John.
Good news. Good news.
Okay, take care. Bye, everybody.
Yeah. JD, you pitched in there at the end. Can you speak to a little bit about what you were thinking?
Oh no, it just Ashley and I actually live near each other and talked, and it's been a while since we caught up. So I'll just shoot an email to you, Ashley, and we'll catch up. But kind of along the lines of the question that I think it was Don that had about, how do you train that local? And that is a big deal because especially for agency nurses who may spend 4 weeks on Epic and all of a sudden they plop down to, a Cerner and they're like, what are we doing here? I mean, I've got plenty of stories of, of health systems that we support. In the middle of the night, you have a new nurse who put in a Foley catheter and they have no idea how to document that. And you would think the hardest part was actually putting that Foley catheter in. But for the nerds on the other side and the administration, they know how important it is to document that catheter because, when I was a hospitalist, I can't count the number of times that I would be consulted on a patient with a fever, and I would say, well, how long has that catheter been in there? And they're like, we have no idea. No one documented it. So it all is connected, and so training and knowing the local workflows, the policies, procedures, the EMR, the tools they're using is really important. So I'll get off my soapbox, and Ashley, we'll just grab coffee or something.
That'd be great. Thank you.
Thanks, JD. Okay, well, I think that's a wrap for this month. Thank you, Ashley. Again, as everybody said, I can really only think of congratulatory and supportive remarks. It really sounds like great work, and we thank you for sharing it with us.
Thank you for having me.
Sure. You're very welcome. Okay, everyone. Look forward to, we'll post notes online, alert you to the location of those. Also pass along the link, video link per request, but also that will be posted to the webpage as well. And we look forward to seeing you all in future sessions. Thanks so much. Bye now.
Thank you all again. Thank you very much.
Thank you.